Hey guys, this is Dr. Shubham. Welcome back to my channel, and today in this particular session we are going to talk about the sarcoidosis. So sarcoidosis is very important topic, but at the same time very difficult to diagnose as far as clinical scenarios are concerned, as far as clinical case to cases are concerned, right? So in the sarcoidosis we'll be talking about we'll try to understand about the sarcoidosis. We'll talk about the types of sarcoidosis. We'll try to know about the investigations, what we can do in the sarcoidosis to diagnose this particular condition, and at last we'll talk about the treatment part. Okay, so let's dive into this topic and let's try to explore the sarcoidosis, right? So if you talk about sarcoidosis, basically this is a multi-system disorders. It means multiple systems are involved over here. That is the first important point. Multiple systems are involved, so I'm just writing multi-system disorder. Okay, so this is the multi-system disorder. Second important thing is that here we are seeing a very important entity which is very frequently tested in the exams also, that is non-caseating granuloma. Okay, so it is a multi-system disorder which is characterized by non-caseating granuloma. Non-caseating granuloma. Okay, or you can say non-caseating granulomatous inflammation, right? So here we'll be talking about the types further, and I will be talking about that it is having two types, which is acute and chronic, right? We'll talk about them. We'll discuss the acute sarcoidosis and we'll discuss the chronic sarcoidosis as well, what are the differences and all. Okay, the investigation part as far as it is concerned, we'll talk about that in detail, but chest x-ray is very first entity which will be doing as far as investigations are concerned, so that we'll be knowing about the lung status, because lungs are very commonly involved. The most common organ involved in the sarcoidosis, that is the lung, so that's why x-ray will be done over there. And if we will be suspicious about the x-ray, then we can take the help of HRCT as well, right? As far as treatment is concerned, 50% of the patients, majority of the patients, they will be non-symptomatic or asymptomatic, so we don't need to treat them as well. But some patients will be there who will be requiring the treatment as well, or who will be going in the severe stages. We'll talk about the stages also in this particular session of the sarcoidosis. So for those patients, we can start with the oral steroids, and we can take the help of some other immunosuppressive agents as well. So that was the basic idea about the topic. So this is a multi-system disorder. Multiple systems will be involved. Most common system will be involving over here, that will be the lung. Okay, and it will be characterized by non-caseating granulomatous inflammation, right? Okay, just adding inflammation as well, non-caseating granulomatous inflammation, right? Okay, so if you talk about the epidemiology wise, okay, most commonly, right, you will be seeing this particular disease in 20 to 30 years of age. 20 to 30 years of age, and basically more common in females as compared to males. For around 2:1 ratio will be seen, right? It is 10 times more common in black people, or you might say 10 times more common in African American than whites. Okay, African American. In most of the MCQs, they will be designing the question in such a way that they will be starting the age of 25 years old or 30 years old female, African American female, or the black female, or something like that. Okay, they will be designing this question in such a manner if they are asking about the sarcoidosis, most probably, right? And it is having two waves. First wave, if the patient will be presenting with a sarcoidosis 20 to 30 years of age or 20 to 40 years of age will be seen. Then next wave can be seen in the females at around 50 to 65 years of age. Okay, that will be the postmenopausal age. Anyways, now what will be the etiology? Okay, what will be the etiology or what will be the cause. However, very frankly, sarcoidosis is poorly known to us. Sarcoidosis can be having so many types. Okay, so it is kind of incidental finding in many cases as well. So it is very poorly understood actually, but whatever we know about this particular disease, okay, we are trying to discuss that part. So etiology, if you talk about, or causes, as far as these causes are concerned in this particular disease, it can be genetic, right? If it is running in the family, or you can say if the father or mother was having the sarcoidosis, yeah, it can involve the children's as well. Some of the environmental agents can cause this. For example, beryllium or its salt can cause the formation of granulomas further. So this I'm talking about non-caseating multinucleated giant cells. They can form the granuloma, right? So that can be there. So environmental factors, so some environmental factors can trigger this particular thing. Okay, it can be idiopathic as well. Very very easy to say idiopathic, unknown cause, and environmental factors. Some of the infectious agents can be there, right? Some of the infectious agents can be there. For an example, mycobacteria can be the major concern, right? Can be the major risk factor. So mycobacteria can be the major risk factor. Fine. Now if we talk about the pathophysiology of this particular disease, right? Pathophysiology of the particular disease, I will not go into much detail, but still will get the idea, right? So pathophysiology of this particular disease, right? In the pathophysiology, what happens is, like, there is a dysfunction of the T cells, right? Basically I told you that it is a multisystem disorder. So basically what is happening, we'll see in the pathogenesis that how the granuloma formation is happening, and at last eventually what happens is that this granuloma will be depositing in several multiple organs, and it will cause the symptoms, and it will be causing the sarcoidosis disease, right? So that is the main thing which is happening. But how this this granuloma is forming, let's try to understand that as well. So I was telling you that the T cells and the B cells activity, okay, they will be disturbed over here, okay, as far as immune system is concerned. So what will happen, first of all, there will be the macrophages. Let's say I'm just trying to just denoting it with macrophages. Let's keep it very simple. That the macrophages, they will be activating the T helper 1 cell. They will be activating the T helper 1 cells. Okay, after that T helper 1 cells will be stimulating the formation of epithelioid cells. Okay, they will be stimulating the formation of which cells? Yes, epithelioid cells. They will be stimulating the formation of epithelioid cells, and further epithelioid cells plus multinucleated giant cells. Multinucleated giant cells. Okay, so basically granuloma is a formation of multiple things, right? So epithelioid plus multinucleated giant cells, once this thing will be formed, right? Once this structure will be formed, then what will happen after that? These epithelioid cells, okay, basically the epithelioid cells, they will be producing the enzyme, a very particular enzyme, which I'm sure you have heard about that at various places. Okay, so I'm talking about this particular thing, right? Epithelioid cells, they will be activating, they will be producing actually one important cell, that is the ACE, angiotensin converting enzyme, right? And they will be releasing some of the cytokines, which will recruit more and more amount of immune cells. So finally what will happen, a mature granuloma will be formed, and this granuloma will be consisting what? Epithelioid cells, macrophages in the center, and which will be surrounded by the lymphocytes and fibroblast. So what will be happening, let's say if this is the right something like this. So these are the macrophages inside, right? These will be the macrophages inside, and around the macrophages you will see the epithelioid cells will be seen over there. Okay, epithelioid cells will be seen over there. Then with some different color you can see the you can see the lymphocytes, something like this. I'm just drawing very vague picture over here. So something like this. Around this fibrosis might happen, around this the fibrosis might happen around this. Yeah, some of the fibrous tissue can be there or something like that, right? So fibrosis can happen, and these kind of things you can see over there. Some of the fibroblast might be there here and there. Okay, so say, let's say these are the fibroblasts which I am showing you with the blue color dots, right? These are the fibroblasts. So this is the structure which I drew over here just now. This is the, yes, this is your granuloma. This is your granuloma, right? And now this granuloma will be actually depositing in the multiple systems, right? This granuloma will be depositing in the multiple systems. Let's say it is getting depositing in the lungs, right? So it will be causing that problem. Let's say it will be causing, it is depositing in the skin, or it can deposit in the heart, right? Or it can deposit in the joints, or it can deposit in any other area. So it will be causing multiple problems in different organs. That's why I told you multi-system disorder, right? We'll talk about detail like what are the problems in the joints, in the lungs, or in the skin. What are the problems? We'll talk about that later on, right? So this is the basic idea. So pathophysiology, once again, macrophages will be stimulating the T helper 1 cells. They will be stimulating the epithelial cells and the multinucleate giant cells. Then epithelial cell will be releasing the ACE. Along with that, it will be releasing the cytokines. And finally the macrophage will be formed. In the macrophage, I showed you different kinds of things. In the center, macrophages, then it is surrounded by the epithelial cells, lymphocytes, fibrous tissues, fibroblasts, and blah blah blah. So all of these things will be making up this dangerous structure. This is the noncaseating granuloma. Okay, so it will be causing the inflammation. Depositing in the several organs will cause the disease. Okay, till now I think we are very clear. Moving on from here. Okay, now this granuloma, one more interesting thing I would like to tell you over here, which will help you to understand other things in the future as well. So this granuloma is having the power to produce one very specific enzyme, right? And name of this enzyme is, so this granuloma is actually producing one enzyme. Okay, what is this enzyme? This is the alpha 1 hydroxylase. Yes, you might have heard about this in your physiology and other classes as well. So alpha 1 hydroxylase, right? Now alpha 1 hydroxylase, you will say yes, it is the enzyme which was converting the vitamin D from its inactive phase into the active stage. So yes, that it is doing that thing. So now what will happen? It will actually causing the hypervitaminosis D. So vitamin D production will be increasing. Due to this, vitamin D production will be increasing. Obviously, due to this, vitamin D production will be increasing, right? Okay. So due to that, what will happen? Due to that, if vitamin D will be activating, it will cause the elevated level of calcium in the blood. If the calcium levels will be elevated in the blood, calcium levels will be elevating in the urine also. So hypercalcemia, hypercalciuria can happen, and possibly it can lead to renal failure. Okay, possibly it can lead to renal failure. Fine. So question might come, it can increase which enzyme? Alpha 1 hydroxylase. Due to that, what complication might happen? Renal failure. Why renal failure can happen? Because it might lead to hypercalcemia, hypercalciuria, hyperphosphatemia, right? These are some of the points you can remember. Okay, fine. Now going to the very important part, that is the clinical features. Right? So clinical features are very interesting and very easy to remember as well. Once you understood the pathophysiology, now it is very easy to understand for us. Just need to know the salient features of it. So in this, I told you, in the initial part, it is divided into two types, acute and severe. So first of all, let's just say that we are talking about the acute type, acute sarcoidosis. Acute, 1/3 of the cases, we are seeing the acute type of sarcoidosis. Sarcoidosis might be asymptomatic as well, so we might not be we might not be able to diagnose the disease, or the patient might not come to you for checkup and all, because the immune system can take care of this particular problem. Okay, so they will undergo remission. So in the acute cases, what we can see basically, so this is a picture which you can actually go through while understanding about this acute cases. So in the acute sarcoidosis, what we can see is, etiology, I told you, like multiple system disorder, you can see over here, right, with the T cell dysfunction, non-caseating granuloma will be formed. We have talked about that, right? Two subtypes are there. One is the Hereford syndrome and another one is the Lofgren syndrome. we'll talk about it. Now epidemiology, as you can see, female more than male, right? Peak age 20 to 40 years, African American woman. Okay, so we have talked about everything about that. Serology, it is negative for the auto antibodies, so it is not the autoimmune as such. So in the lab studies we'll talk about further also. If you will do the bronchoalveolar lavage, CD4 to CD8 ratio will be actually more than double. Now prognosis, spontaneous remission can happen in more than 85% of the cases, and we don't need the treatment, we don't need to treat those patients, and some of them might not come to you also because they will not be having any kind of problem, they will be remaining asymptomatic, so they don't need any kind of treatment also. General symptoms, it can be very vague symptoms like fever, fatigue, weight loss. Okay, these can be the symptoms for very many diseases, right? Now here, okay, in fact the TB also, TB can show the same kind of symptoms, but in the TB you are seeing the caseating granuloma, in the sarcoidosis you are seeing the non-caseating granuloma. That's why the usually we are doing the biopsy of the lesions. So biopsy is very important. Biopsy can tell us actually if it is non-caseating or caseating granuloma. If it is caseating, then it might be TB, and if it is non-caseating, it might be sarcoidosis. Okay, other than TB there can be other diagnoses as well. Now here you can see, if that particular granuloma depositing in the lungs, it can show you bilateral hilar lymphadenopathy. I will show you the X-ray as well, how it is looking in the X-ray. Okay, that's why I told you the importance of X-ray in the sarcoidosis. It might show the symptoms like dyspnea, cough, okay, respiratory difficulty and all. It can actually cause that. Now as far as face is concerned, it can cause, in the eyes it can cause the uveitis, inflammation of your uvea, right? Choroid plexus, ciliary body and the iris, inflammation of the parotid gland, and involvement of the seventh nerve, that is the facial nerve, and due to that it will cause the facial palsy, right? These are some of the symptoms which can be seen in the acute sarcoidosis. Now let me talk about two syndrome over here. One is the Hereford syndrome and another one is the Lofgren syndrome, right? So let me talk about that as well. Other things we have just talked about. In the Lofgren syndrome, guys, these are actually subtypes of acute sarcoidosis, you can say. So in the Lofgren syndrome, guys, what you need to remember is, it is very simple. Just need to remember the triad, right? So what triad I am talking about over here? Triad is very simple, right? Just remember this triangle. Okay, so here we are talking about, in the Lofgren syndrome, we are talking about the joints involvement, and these joints will be having the polyarthritis. So I'm just writing migratory polyarthritis, right? Migratory polyarthritis. So joints involvement. Okay, skin involvement. In the skin it can cause the erythema nodosum. I will show you the lesions also, how it is looking. In the skin it is causing erythema nodosum. Okay, so if the granuloma is depositing in the joint, it can cause the migratory polyarthritis. Okay, erythema nodosum, this is the picture of erythema nodosum. You can see the lesions over here, right? The marked lesions over here with the black boundaries also, which they are denoting. So in the red color lesions, these are the lesions over the skin. So the skin involvement can be considered as this particular problem, right? This is the erythema nodosum. Erythema means red color. Okay, so red color nodosum means nodule. Red color nodules can be seen over here, right? Then in the lungs involvement, right, it can show the bilateral, both sides, hilar lymphadenopathy. Bilateral hilar lymphadenopathy. So lymph node involvement can be there. Okay, lymphadenopathy. Okay, very nice. So we have understood about this particular problem: migratory polyarthritis, erythema nodosum, and bilateral hilar lymphadenopathy. Okay, this is the triad for the Lofgren syndrome. You have understood about the migratory polyarthritis, erythema nodosum. What is the bilateral hilar lymphadenopathy? I will try to show you with the X-ray also. So look at this X-ray. What I can see over here is that in this portion, right, in this particular portion, we can see, yeah, look at this hilar region, look at this hilar region. Both side in the hilum, you can see the inflammatory part. You can see the inflammatory part. Lymph nodes are actually involved. Lymph nodes are edematous. So that's why we are talking about hilar lymphadenopathy. Okay, so I hope you understood this. Remember this X-ray, very important. Sometimes they ask you with the help of this X-ray only that what this X-ray is denoting. So this is the sarcoidosis X-ray, typical sarcoidosis X-ray, where you can see the bilateral hilar involvement, bilateral hilar lymphadenopathy. Okay, now this was about the Lofgren syndrome. What about the other syndrome which they have talked about, that is the Hereford syndrome. So this is the first subtype. Lofgren syndrome was the first subtype of acute sarcoidosis. Second subtype of the acute sarcoidosis is the Hereford syndrome. Okay, so in the Hereford syndrome, what you can remember is, I told you in the image also, right, eye involvement can be there, right. Here also you can just remember the triad, very easy. So the triad is very easy. Eye involvement, in the eye involvement you will be seeing the uveitis, right, uvea inflammation. So uveitis. As far as parotid gland is concerned, parotitis, right, parotitis. And another one is the seventh nerve involvement, that is the facial nerve. So facial palsy, right, facial palsy. So these three features you can actually appreciate as far as Hereford syndrome is concerned. Again, it is one of the subtype of acute sarcoidosis. So here also I just mentioned about it. This is the picture, right. So uveitis, Hereford syndrome, or parotitis, facial palsy. This is the part of Hereford syndrome. This is a part of Hereford syndrome, HF Hereford syndrome. Okay, fine. One more type is there, like jungling disease, but that is a type of chronic sarcoidosis, right. Okay, but this is enough. Then acute, I have talked about the acute sarcoidosis. Let me talk about the chronic sarcoidosis as well, right. So if you talk about acute sarcoidosis, it was how many cases? About 1/3 cases of sarcoidosis are the acute. But if you talk about the secondary, right, if you talk about the secondary sarcoidosis, or I would say chronic, acute and chronic, right. So chronic sarcoidosis, this was acute sarcoidosis. So let me come to this chronic sarcoidosis also. In the chronic sarcoidosis, about 2/3 cases will be seen. So in the chronic, about 2/3 cases are there of sarcoidosis. Okay, so what will be the features of chronic sarcoidosis? Again, let's see this picture. So here you can see multiple systemic disorder. I told you multiple system will be involved over here. So T cell dysfunction, non-caseating granuloma and all. Female, more commonly in female 20 to 40 years of age, African American woman. Autoantibodies are not present over here. What you can check? ACE levels, because granuloma was actually I told you that epithelial cells in the granuloma, they are capable of releasing the ACE enzyme. So that's why if you are seeing the elevated levels of ACE in the blood, that means yes, there is a granuloma which is releasing this ACE, abnormal level of ACE. So that can make the diagnosis. Bronchial lavage, CD4 CD8 ratio, again same, more than double, more than 2 or more than 5. Soluble interleukin 2 receptor, you can check with that also. Complications, some of the complication can be there because most common organ which is involved over here is lungs. So related to the lungs, many features are there: bronchiectasis, pulmonary fibrosis. And if you guys remember, chronic renal failure was happening because of abnormal increased level of alpha-1 hydroxylase, which was causing the hypervitaminosis D, which was causing the hyperphosphatemia, hypercalcemia, hypercalciuria. That's why chronic renal failure can happen, right. Symptoms are very vague: low grade fever, fatigue, weight loss, myalgia and all, right. So here what I can see in the chronic features, if it is if the granuloma is actually with time, it is including the brain and depositing in the brain, can cause neurosarcoidosis. Multiple lymph nodes can be involved, so lymphadenopathy, bilateral hilar lymphadenopathy, this can be seen in the chronic also. Dyspnea, cough, respiratory symptoms and all. If it is getting deposited in the heart, so it is a cardiac sarcoidosis. If it is getting depositing, if the granulomas are getting depositing in the liver, then hepatomegaly. In the spleen, splenomegaly. Scar sarcoidosis can also be seen. In the joints involvement, if there is a joint involvement, then we will call that as symmetrical arthritis, right. Erythema nodosum can be seen here also, right. We can see the bones involvement, cystic bone lesions can be seen over there, myalgia, muscle atrophy and all. Due to the hypercalcemia, we can see the nephrolithiasis, chronic renal failure can also be seen. As far as face is concerned, we can see the eyes, ocular sarcoidosis. We can see the particular types of lesions on the face, particularly, that is named as lupus pernio. These names are very important, guys, because in the questions they might mention about the names also, so you should be very careful. Lupus pernio is one of the popular lesion, can be seen in the chronic sarcoidosis. Maculopapular rashes can also be appreciated, right. might also be seen in these kind of cases. Let me talk about the lupus pernio also. Yes, this is the particular picture you can appreciate. So here you can see in the chronic sarcoidosis you will be seeing the lupus pernio phase. So it is, this appearance is like this. Do not confuse it with the malar rash in the SLE. The malar rash will be actually the malar rash will be what will be showing the complete picture of like this, right? But here you can see different location. So like there is discontinuity in between. So this is not the butterfly rash which you appreciate in malar rash in the SLE. This is not the SLE rash. This is the lupus pernio, which is seen in the sarcoidosis, secondary sarcoidosis. Okay, I hope you are clear till here. Now we have talked about the pulmonary involvement. We have talked about the extra pulmonary involvement also, like outside the lungs, skin, joints, the kidneys, the lungs, spleen, heart. Okay, other things also we have talked about. Now we are actually going to the staging of this particular problem. So staging of this chronic sarcoidosis, stages, if you will see, we are having a 5 stages in total. So these are the stages actually. Okay, so let's talk about the stages of sarcoidosis. In the stages, what we can see is stage 0 normal finding, asymptomatic patients. Okay, stage 1 bilateral hilar lymphadenopathy can be seen, which is very reversible. Okay, so stage 2, the bilateral reticular and the ground glass opacities will be starting along with the hilar lymphadenopathy, and disseminated reticular nodular infiltrates might be appreciated. As the disease progresses in the stage 3, along with the bilateral reticular or ground glass opacities, that they will be there without hilar lymphadenopathy. And the stage 4, there will be the lung fibrosis or the pulmonary fibrosis, right? In most of the cases, this disease will be taken care by the immune system spontaneously, right? Okay, and they don't need the treatment as well. Now, as far as diagnostic part is concerned, so let's talk about the diagnostic part also. How will you make the diagnosis, right? So diagnosis can be very tricky in the clinical scenarios. Okay, but yes, that's how it is. So in the diagnosis, the best initial test is the I told you over there as well, the best initial test will be the CXR, that is the chest x-ray, right? If you are not very sure, or you are not getting satisfaction with the chest x-ray, or you are finding something like, let's say, bilateral hilar lymphadenopathy, okay, you can confirm that with the help of HRCT. Okay, high resolution CT scan, computed tomography, right? HRCT. So you can see what you can see, high bilateral hilar lymphadenopathy, right? Okay, very well. Then if you talk about the lab test, right, you can take the help of lab also. So what about the lab data? Yeah, so let's talk about that as well. In the labs, what we can see is, we can see the hypercalcemia, guys. So increased level of calcium ions in the blood. So we can see what, hypercalcemia. Let me write also hypercalcemia. I told you this earlier as well. Along with that, what you can see, why this is happening in the pathophysiology only, I have talked about, due to the abnormal increased level of alpha-1 hydroxylase. Then ACE levels might be increasing. Why? Epithelial cells were increasing the levels of ACE, right? So that's why ACE levels can also be increasing in this level, in this particular thing. Inflammatory markers, for example, CRP and all, they can be CRP, ESR, they can be elevated. Okay, but these are very vague. But mainly the calcium, hypercalcemia, hypercalciuria, ACE levels can be increased over there, right? In some cases, you can see the soluble interleukin 2 receptors, right? They might be hyperactivated. Then what you can see is that increased level of alkaline phosphatase can be seen in the LFT, right? Increased level of CD4 and CD8 ratio will be increasing. So decreased level of CD4 plus T cells, right? Increased level of immunoglobulin G. So these are some of the things, some of the aspects which you can see in the patients. Hypercalcemia, along with that hypercalciuria also, let me write it over here as well. Hypercalciuria can be seen in the patients, right? So these are some of the tests. At last, we can actually confirm that with the help of biopsy, guys. Very important point I'm writing, biopsy. If some lesions you are seeing, right, in the biopsy, if that biopsy is showing you the noncaseating granuloma, okay, highlighting it again and again, noncaseating granuloma, again it is showing the sarcoidosis, right? Okay, in that particular non-caseating granuloma, two kinds of particular structures you can appreciate, that is the asteroid bodies and the Schumann bodies. They can be asked, might be asked, that's why just mentioning over them, asteroid bodies and Schumann bodies. In the granuloma you can see these two bodies, right? So if in case they are mentioning about them, do not panic, they are talking about the sarcoidosis. Okay, very well. You can do the bronchoscopy. Along with the bronchoscopy you can take some samples from there in the form of bronchoalveolar lavage, and that can also tell about the CD4 CD8 ratio, right? So that can tell us about that also. So bronchoalveolar lavage can be done, right? Bronchoalveolar lavage. Okay, so these much methods we are available with as far as this is concerned, right? As far as differential diagnosis is concerned, right? DDs, what are the DDs in this case? Yes, so let me just write some of the differential diagnosis over here. Sarcoidosis, that can be sarcoidosis. So along with that you might think about TB. I told you caseating granuloma will be seen in the TB. Langerhans giant cells can be seen in the TB but not in the sarcoidosis. Hodgkin's lymphoma, you can actually look for that also, Hodgkin's lymphoma, right? Because the symptoms might be similar to that, so that's why clinically it is not that easy to diagnose sarcoidosis, because other diseases are also there which can actually mimic these symptoms. And then there can be the non-Hodgkin lymphoma, just writing short NHL, non-Hodgkin lymphoma. Pneumoconiosis, it can present like that. Pneumoconiosis also symptoms might be similar, so pneumoconiosis, right? Pneumoconiosis, but occupational history can be there, like silica, dust exposure can be there in the patients. Granulomatous polyangiitis, histoplasmosis, right? These are some of the differentials as far as this particular disease is concerned. At last, coming to the most awaited part, that is the management, treatment of this particular condition. Management, right? So as I told you earlier as well, 50% of the patient, almost around 50% of the patient, they don't need treatment also, because they are asymptomatic and their immune system will take care of their disease. So if they are having only pulmonary sarcoidosis, it means they don't have any extra pulmonary symptoms, they have just hilar lymphadenopathy, so it can resolve back also. I told you in the stages also it is very much reversible. In the stage 2 we were talking about that, it is very much reversible in the stage 1 or 2, right? So in the asymptomatic patient we don't need to touch them. Asymptomatic patient, okay, just observe this patient. Asymptomatic patient, just observe this patient. We don't need to interfere much with the medical management. Observation will do only, right? Immune system will take care of them. Some of the now the symptomatic patient, in the symptomatic patient obviously we need to intervene. So in the symptomatic patient we'll start with the very first drug, okay, and these first line drugs are the steroids, right? The first line drugs are the steroids, no problem with that. Steroids, right? Prednisolone for example, right? Prednisolone, methylprednisolone will take care of that. Steroids per oral we can give orally, right? They will take care of that. In some cases you can, if the steroids are non-responsive in the disease, then you can take the help of some immunosuppressive agents. For example, methotrexate, you can take the help of methotrexate, that is the immunosuppressive agent, or azathioprine, cyclosporin. Okay, these are some of the agents which can take care of these things, right? Some studies showed that anti-malaria drugs can also, you can use chloroquine like that, chloroquine, hydroxychloroquine, but many of the patients can actually they can actually respond to these kind of drugs. Okay, now last resort, if you are talking about as far as lungs are concerned, if severe pulmonary fibrosis happened, then obviously lung transplant is the last option, but that is very rare. Okay, in the rare cases, what could be the complications in such cases? Yeah, so let's talk about the complications also, if you are talking about that much. So complications, as far as complications are concerned in these cases, pulmonary complications I told you already. For example, bronchiectasis can happen, right? Yes, that bronchiectasis in which honeycomb pattern you are studying, you are talking about the tram track pattern and all, right? Pulmonary fibrosis, yes, that can be very severe. If very severe kind of sarcoidosis happened, or if it remain undiagnosed and it went to the stage 4. So yes, obviously pulmonary fibrosis might happen. Chronic renal failure, okay, nothing new guys, just repeating all of the stuff which we were discussing about. Chronic renal failure because of that hypercalcemia, hypercalciuria, hyperphosphatemia. Okay, how about the prognosis in these kind of patient guys? Prognosis, I would say, yeah, in 50% of the patient prognosis is very good. In the asymptomatic patient, we don't need to treat them. 50 to 70% patient. In 10 to 30% of the patient, yes, chronic sarcoidosis might develop. So prognosis overall, I would say the good only, but in some symptomatic patient, yes, we need to just treat them with the medical management. So overall treatment, overall prognosis wise, it is a good disease in the for the asymptomatic persons. But as far as symptomatic persons are concerned, many of the problems like not able to make the diagnosis or something like that. Okay, so these kind of things happen. Meanwhile, you are actually testing your patient, running multiple tests. The patient might fed up and might change the doctor, and the sarcoidosis might not be diagnosed but very well. So that can also be the case. Okay, so this was about the sarcoidosis main idea. Let's just test our knowledge in the MCQs also. So very first MCQ says that there is a woman who present to the clinic for evaluation of chronic dry cough. Obviously this is a respiratory symptom for 3-month duration, and she denies any shortness of breath or hemoptysis or night sweats. It is not present, or weight loss, this is not there, but does endorse occasional subjective fever, joint discomfort is there, and recurrent crops of painful nodules over her legs. If you guys remember, on the legs I told you nodules, reddish kind of nodules. Yes, that name was erythematous nodules, right? Okay, erythema nodosum. Her temperature is 99.2. okay, there is fever, pulse is 60 per minute, BP is 112/74, no issues, respiration 14, that's fine, oxygen is fine, 78% on room air. Lab test shows this data. Okay, so it looks normal to me. TLC count is 7200, 4 to 11 is the normal range. Hemoglobin 12.1, that is not the issue. Platelet count 4 lakhs, that is also not the issue. Sodium is fine, potassium is fine, chlorine is fine, bicarb is fine, BUN, and creatinine level is under control. Okay, glucose, calcium, look at the calcium levels guys, calcium levels, okay, 11.5. okay, so bit elevated over here I would say, and phosphorus 3.2. so which of the following radiograph would you consider for this particular disease? So I would say first of all we should diagnose, then we'll talk about the x-rays over there. They said that they were the patient is having fever, the patient is having joints problem, the patient is having polyarthritis, okay, joint discomfort, or I can say arthritis. The patient is having nodules on the leg, skin involvement, erythema nodosum, right? So these kind of things are seen in the what? Yeah, looking like acute sarcoidosis. So this is the diagnose. Yes, diagnosis will be the sarcoidosis. According to us, diagnosis will be the sarcoidosis, seeing that calcium levels are also bit elevated. 8 to 10 is the normal range. Okay, and it is given 11.5. so hypercalcemia and all. Sarcoidosis is the diagnosis. Let's look at the x-rays over here. X-ray option A is looking fine to me. X-ray option B is showing the lobar consolidation. It is not the finding of obviously it is not the finding of sarcoidosis. B is also not the answer. Let's talk about the C option. Yes, in the C option I can see hilar lymphadenopathy both side, bilateral hilar lymphadenopathy. So this is the right answer over here in this case. So yes, this is the right answer. Okay, and then D option, yes, in the D option the fibrosis can be seen over there. So this is not the option as well. If the patient was talking about fibrosis, then the vitals will also be not normal, also respiratory rate will be very high, and the saturation will be dropping, which is not seen in this particular case. So answer over here would be the option number C. I hope everybody is clear. And option C shows that there is bilateral hilar lymphadenopathy guys, bilateral hilar lymphadenopathy. I hope everybody is clear, right? Okay, moving on to the next question guys. Question number 2. A 40-year-old woman, she is presenting to the clinic for malaise, right? Now she has been in her unusual state of health until 2 weeks ago, when she noticed weakness and dyspnea upon exertion. She denies any kind of orthopnea and paroxysmal nocturnal dyspnea or weight loss. No, nothing is there. It is ruling out the TB guys. By giving this kind of history, it is ruling out the TB. She endorses occasional fevers but has not checked her temperature at home. Okay, she also reports worsening pain in her eyes that occasionally causes headaches and occasional joint pain. Her temperature is 98.6, BP is 120/70, pulse is 70 per minute, respiration is 15, everything is fine, vitals are normal. Injected sclera, sometimes it can be seen, right? Bilaterally. She denies pain with any eye movement. Her lungs are clear to auscultate bilaterally. Cardiac auscultation shows S3 with an occasionally split S2. It means heart involvement is there. It means eyes involvement is there. Joints involvement is there. Head involvement is there, right? And she talking about the weakness also. Chest radiograph is showing in the figure A, and in the figure A I can clearly see bilateral hilar lymphadenopathy. Yes, look at the diagnosis. Yes, I know you are actually saying the diagnosis very loud and clear, but still let's look at the B picture also. They said her lower extremity revealed skin finding shown in the figure B. Okay, and chest radiograph in the figure A. Figure A we actually done with that. Figure B, it is showing the skin involvement in the legs. And yes, I want to actually listen from you, what is this involvement? Yes, this is the skin involvement. The name of this is the erythema nodosum. Yes, the name is the erythema nodosum. And diagnosis would be the sarcoidosis, actually acute sarcoidosis. Okay, and there was one syndrome I told you in the subtype, Lofgren syndrome. The Lofgren syndrome I told you, erythema nodosum, bilateral hilar lymphadenopathy, and the migratory polyarthritis. In this case, I don't know, joints involvement is there, occasional joint pain, guys. So this diagnosis, look at the options are very easy actually. So diagnosis will be the sarcoidosis, answer will be sarcoidosis, but actually very specific answer if you are asking, then it is the acute sarcoidosis. And to be very specific, it is the Lofgren syndrome, guys. And Lofgren syndrome was the subtype of acute sarcoidosis. So I'm sure that you don't have any kind of problem while solving the sarcoidosis MCQs. I hope you enjoyed this session, guys. If you did, please hit the like button, share this video with your friends, and please do subscribe. Thank you so much for joining this one. I will see you in the next one. Bye bye, take care.